met a few ladies who have come to my practice seeking treatment for their fibroids and saying, oh, I want this done, I want that done, when in actual fact, their fertility is yet to be tested. If at the time you're having your fibroid surgery done, you're yet to have a partner, and you're of a certain age where we know that the egg reserve is beginning to go on its decline, I would beg of you, I would really beg of you to consider those interventions very.
Hello, welcome to AskAwayHealth. Today we're going to be talking about fibroids as they affect fertility. Thank you so much for joining me. I'm Dr. Sylvia, a general practitioner and health educator. I'm really thrilled to have a special guest with me today to talk about this subject. We have been discussing fibroids and how it affects women throughout this month of July, which is Fibroids Awareness Month. And I hope that you have been going through our other resources on the channel. If you haven't, please make sure you like this video, subscribe to the channel, and go and check them out when we are done with this particular episode. But stay right here. I'd love to introduce to you our special guest, who is a seasoned obstetrician and gynecologist with interests in ambulatory gynecology, medical education, and complex obstetrics, focused specifically on preterm birth and benign vulval disease. It's a pleasure to have you here, Dr. Tolu Adedipe. I'll just add her to the stream. Welcome, welcome. How are you?
Thank you very much for having me. It's a pleasure. It's an honor to join you again. Thank you so much for asking me on board. And more importantly, thank you for the great work you're doing for our women, educating, teaching.
Oh,
and,
thank you. Thank you so much. I appreciate your support. Thank you so very much. Right. So we're going to dive right into this because clearly fertility is an issue that we as women, we have on our minds. Most of us have on our minds. And when you add fibroids into the mix, there are some concerns. And I think we're going to go through as much of them as we can as possible in this conversation today. So let me just pull up your slides and then let you start. So I've got the first slide up. So I'll let you go through, and then after we'll take a little bit of a break and then dive into the questions.
Fantastic. Thank you. Great. So fibroids and infertility is what I'll be talking about today. I'd rather call it subfertility rather than infertility. Just a little nuance. And I do this with all due respect because I do know how subfertility can affect couples, particularly the women in certain societies. We're both African or African extraction, and we know how a woman's being is seen in terms of her ability to produce.
Yes.
After a kind. So it's a very sore subject, very emotive subject, and I'll try to delve in gently, but given the facts as they are, and not being carried away by emotions. Okay. So, and we also know fibroids is rather common with women, within women of African extraction. So needless to say, you can imagine the strong association women have subfertility with their fibroids, when it's unfortunately, in many cases, they be completely unrelated. We also have learned that fibroids are rather common in 20 to 80%, depending on the population. 80% more so in women of African extraction. Now, as you can see on the screen, we only find fibroids being directly attributable to subfertility in only 1 to 3% of cases, whilst a double or a triple of that number will be seen whilst being investigated for other problems, i.e. 5 to 10% will be observed to have fibroids whilst being managed for their subfertility due to other causes, but not directly related to their fibroids. So I hope these numbers provide some degree of reassurance to that woman who's been told she's got fibroids and who is still seeking to have children, whether initially or maybe after a slight lull after having one or two. I have to say here, like I've mentioned earlier, when infertility has a multifaceted etiology, or should I say causation. I'll be talking about that later. Not just the woman alone that needs to be examined, the man also needs to be examined. I always say it takes two to make a baby.
It does.
Although, with the way the world is going, maybe in another 10 years, it might not take that two to make a baby. But we'll wait to see.
Oh dear. Okay.
But coming back to the fibroid effects on fertility, I would insist and say to my ladies, that's my patients, that we need to know the size of this fibroid, the number and the site of this fibroids, and of course, other things the woman may be coming with. So are there other conditions that might impact her fertility? Are there other conditions that might impact how we manage our fibroids, and also are there other conditions that may ensue during the course of treating the fibroids, and therefore overall quality of life may be in question. So we'll go next to the second slide to talk about the site size and number, which figure, that's the International Federation of Obstetricians and Gynecologists that kindly classified. So you can see there on that table, you've got the 0 up until, I believe, 8 or so.
Yes.
Now, the fibroids sitting in the uterus, that's in the womb, are buttoned into the cavity where baby would lie or sit, are determined as submucosal fibroid. And submucosal fibroids, as you see at the top of that table, could be 3 types. So you could have one that sits completely in the cavity and is connected to the lining of the womb by a very thin stalk. We call that a pedunculated one, pedunculated intracavitary fibroids. We then have the second set, which is it's coming into the cavity, but not completely into the cavity, but we say more than 50% is into the cavity, meaning less than 50% is within the wall of the uterus.
Sorry to cut in. Can I just share a photo or an image, which I think you can see as well, just to see if that helps to clarify what you mean?
So you can see the pedunculated submucosal sitting in there like a foreign body, or almost like a coil, for instance, which is one of the mechanisms that this impedes, fertility or implantation. Okay. And then you can see the second one, I think on my left, where a lot of it is in the cavity, but not completely into the cavity. And you would call that, possibly looking at it, a type 2, because less than 50% is into the cavity, but most of it is within the wall of the womb. And then we then have the type 3, which is the intramural fibroid. So the intramural fibroids are the fibroids that sit well within the muscle of the womb, but impinges a little bit into the cavity. And then we have those that sit completely within the muscle. The cavity is still nice and lovely. There is no alteration. There's no impingement. And then we go on to have those that impinge within the wall into the outside. So we're talking of from the inside to the outside. And then eventually we end up with the type 8, which is the pedunculated one, which sits largely in the outside and has no correlation or no effect on the cavity. That's the endometrial cavity, which is where baby would be sitting, once the fertilization has occurred. So I'll go to the next slide now. We find that for those fibroids that have an impact on fertility, we will tend to say we would look largely at types 0 to 2 and to some degree type 3, depending on the size of the fibroid. Because if you've got an intramural fibroid that impinges a little bit and makes the cavity a little distorted, or has an impact on, for instance, where the tube feeds into the uterus, as you sometimes have in the cornal fibroids, then you can imagine there will be some impact on that woman's fertility. Now, the fibroid effects we expect will be looked at from different angles. Is there a problem in insemination? So, for instance, we have seen very few cases, quite rare I must add, where the fibroid sat in the cervix, kinked the cervix, so therefore there was no adequate free flow of menstrual blood all the way out. So
this is where you have, normally we look at fibroids that's happening within the body of the womb, but now you're talking about fibroids in the neck of the womb now, in the cervix.
In the neck of the womb, yes. And therefore had an impact on the free flow of menstrual blood. And you can also imagine in reverse order, it will have an impact on free flow of semen into the uterus, to let it get into the uterus and into either fallopian tube to, catch that egg to get a baby. And by default with fertilization, and also I put beside it travel. So it's traveling, you see, from the vagina into the cervix, through the uterine body, and through both tubes, And the common effect we know of with most fibroids will be with implantation. And that's where the type 0 to 2 become very important, because they have an impact on that ability of that conceptus or conception, as it were, to come down into the uterine cavity and implant. And if by chance the woman is lucky and the conceptus is able to implant, then we also talk about embryo development. Because the fibroid is a foreign body, it makes for a very hostile environment. And you find that the microdynamics is such that you need to have, should I say, a very enabling environment for the embryo to develop. And unfortunately, in some of those women that doesn't happen.
So what you're saying is that the fibroid is actually competing with the baby because the baby needs the womb environment to support it. That's the whole essence of everything women go through to get ready for pregnancy. We talk about getting the womb ready, but now the fibroid is actually competing and making that environment suitable for itself and depriving the baby. That's the problem.
Certainly. And the levels of competition would vary. Some levels of competition are such that very early on in the pregnancy, it overpowers the baby or it overpowers the embryo. And unfortunately, that leads to a very early miscarriage. However, some levels of competition may be slower. And therefore, yes, the baby is trying to thrive, but unfortunately does not thrive as much and then ends up in a miscarriage much later on. Particularly where the lining of the womb is completely plastered or pebbled, as it were. And therefore, the placenta of the baby is unable to invade. I use the word invasion with all due respect, but that's the way it is. The placenta literally digs deep
into the womb lining.
Into the womb lining, you see. But if the womb lining is completely distorted by multiple fibroids, you can imagine how difficult that will be. It's like you trying to plant a rose in pebbles as compared to you planting a rose in good soil.
Yes.
And the competition still carries on in some situations, even after the first 13 weeks of pregnancy, which we liken as the first trimester, into the second trimester, and sometimes even all through the pregnancy, with this baby actively competing against this hostile environment. And that's what we talk about when we say a growth restricted baby. Because why? The amount of food for that baby to be sustained, to grow as robustly as possible, is simply not there.
Okay.
Apart from the implantation side of things, or should I say competition from the implantation side of things, if you've got large fibroids, humongous, well, you call them humongous because they are actually humongous. So we're talking of fibroids around 10 centimeters. 10
centimeters and more, yeah.
And more. You know, you can also imagine the poor lady, she's got a 10 centimeter fibroid tucked somewhere, and then she's got this big baby, or should I say a growing baby, who then has to be restricted because her tummy can take just so much.
Yes.
And that leads sometimes in some women to preterm labor risk because the tummy can only expand so much. And at some point, this baby is forced not to grow as much because there's simply no room to play. You see?
Yes.
Babies need rooms to play. They need to exercise their limbs and, jump around and turn around. So the gymnastic heroes were not made just on the track outside. They've been gymnastics, or the football heroes have been playing football for a while in their mother's wombs. But they need that adequate space to be able to play and, as it were, thrive. And this is how sometimes fibers can also have an impact. Then we then get to labor and delivery. I know fertility is what we're talking about here, but labor and delivery all come hand in hand because it's not just about falling pregnant, it's about keeping the pregnancy all through the 40 weeks of pregnancy. In some cases, fortunately, come a little early, but it's also about delivering this baby so that we have a happy mother, a well mother, but also have a happy and a well child.
Yes.
And if the fibroid is in the way, i.e., if it's in the neck of the womb, you can imagine delivering past that fibroid may come with some difficulty and might need or necessitate either a cesarean section to deliver via the womb. I have to say, though, I have to put a caveat here. Not all cervical fibroids are in the way. So this is why you need to have a very good discussion with your healthcare provider to be able to have an understanding. I do not want this to create any degree of anxiety because there are things we can do without necessarily going down the route of a cesarean section. This is only for information purposes.
Okay, that's good to know. Okay, that's fantastic. So just from this slide, you've taken us through potential fibroid effects on a woman's fertility. Even before conception, we've looked at what could potentially happen just during sex, from getting the sperm into the vagina and towards the tubes where fertilization will happen, all the way to possible effect at delivery. And I mean, that's amazing. And I'm so glad that you said something at the beginning. I'm so glad that you said, because we're so worried when we hear fibroids, the first thing we start to worry about, well, for most women, is fertility. Can I still have children? I'm so glad that you gave us that percentage, that despite what we hear, the fact is that 1 to 3% of women with fibroids, because that's what we're saying from this slide, isn't it? That there is a small, it's significant, but it's relatively small number of women whose fibroids will affect the chances of having a baby. Is that right?
Correct.
Good. Okay. So can I just ask you then, just to clarify, before we go into the questions, and you've given us a lovely background. So just for the sake of our viewers, and you talked about subfertility. Generally, we will, my patients will talk about infertility. Is there any difference in the mind of the patient? To you as a clinician, yes. But to the patient, should they be, when she says subfertility, what does she mean? How is that different from infertility? Could you clarify that for us, please?
Oh, you're really putting me on the spot here, Auntie. Because I think I won't give you exact figures, because the figures would range from the demographical characteristic of a woman. So for instance, I'm talking to a 20-year-old girl or 25-year-old girl, I'll be giving her different figures as compared to talking to a 40 or a 45-year-old woman.
Right.
And certainly, if I was speaking to a 25-year-old girl who's had 3 kids, that's going to be quite different to talking to a 45-year-old woman who's yet to have a baby.
That is true. So, okay. All right. I'm with you. That's fine.
The figures are quite variable. But what I would say is, from the psychology of the disease understanding, you were to say to a woman infertility, it makes her feel it's insurmountable. But you were to say to a woman subfertility, it makes her feel, yes, there are challenges. There are challenges. That's why it's sub, not super.
Yes.
Okay.
Yes.
Yeah. So there are challenges, but you know what? Let's sit down at the table. Let's get through this investigations, and then let's see what we can come up to overcome this challenge.
Amazing. That's fantastic. I'm so glad that you said that, because there has to be hope. And unfortunately, the story out there is, it's no use, or it's full of pain, and it's full of all sorts of difficulty. But actually, there are things that could be done. So I'm so glad that you put that in. And so that leads us nicely, after this background you've provided, to the first question, which is on the screen now. And so what specific factors, and I think you've probably covered that, but I'm going to let you see if you want to add any bits to it. What specific factors related to fibroids can impact my ability to conceive?
I think I'll just rehash what I've said earlier about the size, the site, and the numbers. So certainly, if you had fibroids of a type 0 to 3. And when I say type 3, I say with a caveat of a large type 3 rather than just a small type 3, for instance, then yes, that might have an impact on your ability to conceive. But this has to be taken some degree of, what's the word I would use now?
Caution?
You have to be cautious of caution, yes. Yes. Because we've got to make sure we've ruled out other factors that impacts a woman's ability to conceive. So I believe my 4th slide talks about, reasons for infertility. And I've stated it very clearly there. There's a male factor. We can't afford to ignore the male factor, because the male factor is significant in 15 to 30% of cases. Okay. And that would include the sperm quantity, quality, and also travel. Okay, I keep using the word travel to talk about, for those who have problems with the vas deferens. That's the tube that connects across. Okay, then we go to the female factor, where structure, and you can see I've put there, in some women, they may have a congenital structure. So it's not just fibroids alone. They may have a septate uterus, or, uteri that have there's been a bit of a, should I say, a little stop in its development, so to speak.
And so they're born with this, they're born with these abnormalities. That's congenital, isn't it?
Exactly. And then we talk about the ovarian function, which is very important and very, very common. So with that, we talk of polycystic ovaries, which I'm sure a lot of women know. By the way, I need to make a note here. Polycystic ovaries and polycystic ovarian syndrome are 2 different things. So women would say they've had a scan and they mentioned one ovary had a polycystic look. Darling, you still need to get more scrutiny before you can then label yourself as a polycystic ovarian syndrome lady. So please. Okay. And then we talk about hypothalamic disease or disorders. And a very common one, for instance, in women who are trying to lose loads of weight to look a certain way. And that has an impact on their ability to, release eggs. We say to those women, possibly because of the intense weight loss regime or intense exercise regime, for instance, they have what we call anovulatory cycles, where, yes, they're bleeding, but they're not releasing eggs at all.
Ovulating. Okay.
And the most important thing is the tubal dysfunction. So that is from adhesions, from surgery, which we will talk about. Because I'm making a fuss about this because women often come saying, oh, they've got fibroids, they want surgery. Surgery does not go without its own risks.
Of course.
The risk of adhesions are there. So what you do not want is a situation whereby you're jumping from presumed infertility to certain infertility in the event of unfortunately developing adhesions secondary to surgery. Yes, we have agents, okay, we have barrier films, we have barrier membranes we put in order to minimize adhesion formation. But, as with everything, never say never. And one woman's healing process is different to the other. And of course, the very common thing is STIs, which I have to make a fuss about because unfortunately, we're beginning right now in the United Kingdom to see a resurgence in the rise of syphilis.
STI means sexual infections, which I know my viewers will know, but just to be clear for anybody who's not familiar. So STIs are sexually transmitted infections. But go on, please.
So we begin to see a resurgence in certain STIs, namely syphilis. So I definitely want to put it out there. If there's something you can protect against, if there's something you can prevent, certainly it's that factor.
Okay.
We all know, any young lady now knows that chlamydia is an unspoken STI, whereby it's oftentimes symptomless but can be quite devastating.
Absolutely. And
of course, we then talk about ectopic gestations, which is unfortunately the sequelae as a result of that, where maybe a tube has had to be taken out. The autoimmune conditions are put in stars because the incidence is quite low and the research behind it is growing. I will not deny that a group of women will have this natural killer cells, which unfortunately attack the embryos. However, I think we still need more information, and they wouldn't really present as subfertility per se. These are the women that will present with having had several miscarriages, and with each miscarriage coming on earlier than before. So I've had women, one or two, who've come to see me in clinic saying, "Oh, doctor, I've had 14 miscarriages,
Oh,
and
wow.
the only thing, so not very frequent, but the numbers are growing. The disease or the condition is being better recognized, better investigated, and then better referred to the designated treatment centers. Because, of course, you can imagine not everybody is able to provide that adequate management for this unfortunate group of women, but it is that. So those are the factors, those are the background factors you have to take on board. So when I say to women saying, oh, the fibroids impacting my ability, I think the first thing I want to do is to rule out all these other factors, okay? So once these other factors are ruled out, amongst one or two others I've not mentioned, then I can then say categorically, okay, fine, fair enough. It may well be that your fibroids may have an impact on your ability to conceive, and then we then need to go back to the drawing table to identify how do we proceed with this. So is the site of the fibroid being in the way? Is the size of the fibroid or fibroids, also having an impact? And the number of the fibroids certain, contributory to our infertility are the questions we then need to ask.
That's amazing. And I'm so glad that you've made that very clear, that this is what, as a specialist, this is what you look at, because women will come to you and say, because of what they've heard, that fibroids can prevent you from getting pregnant. They will come to you and say, well, I want my fibroids taken out because this is why I'm not getting pregnant. Well, I'm so glad that you've explained to us the different possible issues that you have to look at first before assuming that, or before assuming all those other factors you've mentioned are negative or are not the cause before looking at the fibroids. So I think that is really important, and I'm sure that our viewers and those watching will appreciate getting that clarity. So let's go to the next question, which looks at explaining the potential mechanisms by which fibroids can interfere with pregnancy and implantation. And again, not to jump the gun, I've just put it here because it's a common question. And I think that it's something that you also covered in that very important discussion, this thread that you shared about the fibroid effect along the entire pregnancy journey. I don't know if there's anything else that you want to add in this area in terms of potential mechanisms, anything else that the fibroids may do to affect pregnancy and implantation?
No, I think it's been covered extensively by the thread, and no, I don't think I would add anything to it other than just say yes. The fibroid basically acts like a sort of intrauterine device.
Okay. So if anybody's watching this on the replay, we're going to put timestamps and make sure that it's clearly labeled. So if you want to jump straight ahead to understand how fibroids could potentially affect pregnancy right from the time of intercourse all the way through to delivery. But bear in mind that even though we're discussing this, we don't want to raise any alarms. We're saying that studies tell us that we're looking at a direct effect of 1 to 3%. So it's still small. Though significant, it's still small. And the key thing that Dr. Tolu is telling us here is that it's not insurmountable. Potentially, there are different measures that could be approached. So she's talking about subfertility, wherein there is a challenge, but it is possible to overcome it. And I think that's a very good note of hope to sound for our ladies to hear. All right, so on to question 3. And question 3, Dr. Tolu, it says, are all types of fibroids equally detrimental to fertility, or are some types more problematic than others?
So this is going to go back to that second slide, isn't it?
Yes.
Whereby, like we've discussed earlier, the submucosal types have been associated with subfertility. So will I say all types of fibroids are equally detrimental? I'll say definitely not. So and even within the submucosal group, I can imagine that depending on the sizes and also where they are sited in the uterus, you can find that the impact will vary. Sometimes more problematic, certainly, given the effect it has.
Okay. So if I draw my viewers' attention to the diagram beside the table, which is, I think this is the best way to say it, is the womb of a woman who is lying down, because it's in that sort of position. But if we look at the ones that we're calling the submucosal, are the fibroids in position 0, 1, and 2. So we can see how 0 is right within, that's the pedunculated one. So it's right within the womb cavity, isn't it? And that's one of the ones that you talked about, how we can create that horrible environment that is unfriendly to a growing baby. Similar to number 1 and number 2, they will do the same thing. So those are the ones that you are referring to in the context of that discussion, weren't they?
Yes, certainly.
Okay. Yeah, absolutely. All right, that's fine. So let's go to the next question. I think this diagram very clearly, very nicely describes it. So the next question is, are there any specific tests or diagnostic procedures to determine if my fibroids are affecting my fertility?
So yes, there are specific tests, and that's one of the reasons why I would say when it comes to infertility, you need to look at the entire picture.
Okay.
So part of the test the lady would go through in order to investigate her, at least at the secondary care level, will include a test to see whether a tubal function is adequate. So, and that's done by a series of tests, namely from the X-ray with contrast, which is called the HSG, and sometimes it would be. Don't worry, I don't have the slide there.
I was just running through just to see if you had any listed, but that's fine. I'll leave it on here.
Yeah. Great. So there's several tests we do to check for tubal patency, actually, not pathology, tubal patency. Because remember, we need the travel. We need the corridor for the embryo to travel down, or we need the corridor for the sperm to travel up to the egg. So if a few of those tests will be things like HyCoSy, HSG, or the hysterosalpingogram. In the event of not getting very good views, or depending on the service your local provider has, so women have been known to have a laparoscopy and dye test in order to assess the tubal patency and function under general anesthetic, that's it. So yes, oftentimes you would find, particularly when assessing for tubal function, you would find if there's any sort of impingement of the fibroids onto the cavity. If, for instance, you have an X-ray test, for instance, or if you were having a laparoscopic test, you would see the fibroids sat in there. You might also at the same time want to carry out a hysteroscopy, particularly if an ultrasound scan, a pelvic ultrasound scan, has identified that. So a rehash of this, first and foremost, a pelvic ultrasound scan. And you want it detailed at that. So you want them providing for you the size of the fibroid, the site of the fibroid, and how close it is either to the cervix or to the conura. So the conura is basically where the tube feeds into the uterus. After which you might then want to check for tubal function, because sometimes being close to it does not mean it impedes the function majorly. So you might want to see how it actually functions. And this is where the hysterosalpingogram becomes quite useful. That's the X-ray. So the X-ray with contrast will highlight the cavity of the uterus, and it also would highlight if there's any free flow or adequate spillage of the contrast through the tubes into the woman's pelvis or abdomen.
And that tells us that the tubes are open.
Yes, that tells us that the tubes are open. And if that still doesn't quite work, then this is where a laparoscopy dye test, so that's putting dyes through the neck of the womb from the vagina, and then waiting to see it spill on either side in real time, under general anesthetic. And also, potentially, you could also perform a hysteroscopy at the same time, or just before that, to also assess the cavity to make sure there is no impingement of the cavity by fibroids or even polyps.
So this test will tell us, they can tell us quite a lot from the scans telling us where the fibroids are located, to the HSG and X-rays, telling us whether the tubes are open, and then to things like the laparoscopy with dye or the hysteroscopy, actually looking into the womb, telling us whether these fibroids actually affect the space within the womb, or if they're pressing on the, like you said, the conura, the exits or the entrance of the tube into the womb, which can affect the sperm traveling or the fertilized egg coming into the womb. So those are useful tests actually that you can, well before you start thinking about any surgeries or any treatments, this can actually tell you what the possible impact of the fibroids are. So we should be making sure that our patients are seen as soon as possible in specialist clinics, and women should really be shouldn't really sit down worrying and doing all sorts of different things, coming quickly to the specialist to actually get this test, so we know what is going on, your specific fibroid, and how it could impact your fertility. Coming to do that early is important. Okay, so let us go to question number 5, which is, what treatment options are available to preserve or enhance fertility in individuals with fibroids, and what are the success rates associated with these treatments?
So this slide basically talks about all the interventions we can perform. But speaking, should I say, responding directly to the question, there are several treatment options. So what I've listed here, should I say, are like surgical interventions, but I would want to break it down into 2. So there are treatment options that can preserve your fertility because the fibroids are not quite big enough to have a significant impact on your fertility. And those treatment options would include, the medical treatment, for instance. So be it the pill, that's the progestogen only pill, the implant, or the Mirena coil, which is a progestogen intrauterine system. Progesterone, yes. So intrauterine system. I'm just mindful that just in case we have people from overseas that are not very conversant with Mirena, so I thought I better call it by the generic.
Yeah, that's true. Thank you. Yeah.
So so to preserve the fertility, yes, you could look into this. So to preserve fertility does not always have to be a surgical thing. It doesn't have to be. Then in addition to that, I think there are new interventions coming into play now, such as the MRI, ultrasound focused therapy.
Yes, guided ultrasound, yes.
So basically, you've got the hormonal treatment, and then you've got, this new treatments that are coming out. I had to put a caveat here, though. The new treatments, that's the MG focused ultrasound and the RVTA, are still increasing their number of patients. So in many centers which utilizes interventions, it is largely done under the, should I say, the umbrella of research.
Okay.
And by default, they might require that the woman has completed the family. So we need to wait a little while before we get a bit more information.
Okay.
Then, of course, how can I forget uterine fibroid embolization?
Of course.
And even though UFE started life similar to,
MRI
and the MRI, we're beginning to now report case series of women who have gone on to have children, following UFE.
Okay.
However, there still has to be care with UFEs because depending on the site of the fibroid and also depending on the number of the fibroids you're looking to treat, these measures are not seen as the usual sort of interventions. But to
Okay.
preserve or to minimize the fibroid getting bigger and therefore becoming a problem later on, I would simply stick my money with the hormonal treatment or the interventions first.
Okay.
Now, to enhance fertility, so I like the way you've actually worded this. So one is to preserve, the other is to enhance fertility. So to enhance fertility with fibroids, then of course we want to also make sure that we are getting on board things to enhance fertility generally.
Yes.
And that would include, lifestyle choices, making sure healthy diet, preconceptual vitamins, exercise, all the background. Yes. And then for those women who have been found to have subfertility linked to their fibroid, then we can start talking about this treatment.
Okay.
Because the treatment do have their side effects or their potential risks. And therefore, the decision to go ahead with any of this treatment has to be made very carefully in an individualized care pattern. So what we do know is we have the myomectomy. So the myomectomy, which is removing the fibroid, can be done either hysteroscopically, which previously was hailed as a transcervical resection, TCI. And with this, what we do is we put a camera through the neck of the womb from the vagina. And then once we target the fibroid, particularly a type O or a type 1 and sometimes type 2 fibroid, we then try to, as it were, chip away at it until we get rid of the entire fibroid as best as we can. Of course, this procedure comes with its risks. Bleeding, infection. In some cases, if the fibroid is rather large, there have been unfortunate situations where in order to chip away or to scoop away, as it were, some of this fibroid tissue, guess what? We've basically made a hole through the uterus. Exactly. Into the pelvis.
Right.
So a perforation has occurred. So it's something we have to consider really very carefully.
Okay.
What we also are concerned about is we do know that depending on the site of the several fibroids. So let's imagine, for instance, you've got a fibrous sat in front and you've got a fibrous sat at the back, and then you will scoop it away. Guess what would happen? Scar tissue will develop in front and scar tissue will develop at the back.
This is what you said at the beginning. This is what you said about being careful when a woman comes and says, oh, can I have surgery for my fibroids? Sorry, I just remember that you were very emphatic about that.
Yes. So there is a risk of there being scar tissue, which can then obliterate the cavity. So 1 minute you have a cavity that is a bit bumpy, and the next minute you have a cavity that is looking almost like a 2-lane or a highway with something right in the middle, and that's because of the scar tissue. Now we have things we can do to minimize that. So for instance, we would leave a coil in place, and we would also fill the cavity with a bit of adhesion reducing agent. But like I would say, every woman heals differently. So it's something to be taken on board when this decision is made. I have to be careful because I do not want to give too much information that will scare women and push them away from seeking help. But I also want them to just understand some of the difficulties we face when we're in theater with these ladies. We do know that success figures, like say fertility figures are improved with the myomectomies. We know that in the first 3 to 6 months, depending on whether you have a hysteroscopic myomectomy, actually, I suppose you could, once you've had pretty much a smooth post-operative recovery period, I would say maybe within 3 months or so, yes, you could start to try for a baby. After, of course, you've been checked out by your provider. I wouldn't give a certain number of months because it depends on how many things you had done. And how potentially difficult it was. So I would say certainly whoever your specialist is, you need to listen to them very, very carefully to guide you as to how soon you want to be trying for a baby. For the bigger myomectomy, particularly if it's a large fibroid, so you can see there, we normally would tend to say a laparoscopic excision is much better. A laparoscopic excision is basically through keyhole surgery for the provider that can provide the service, for instance, keyhole surgery, and then we scoop out, as it were, the fibroid as best as we can. We know there have been several studies, there have been several meta-analyses of case series studies that would suggest that the laparoscopic excision provides for quicker recovery, less blood loss, and a shorter hospital stay.
That's compared to, and that's compared to the traditional myomectomy. Yes. So this is laparoscopic excision going through the abdomen but using keyhole, and that is better in terms of outcome compared to the traditional version, an abdominal myomectomy, where you have to make a wide cut into the abdomen or the pelvis to access the womb. Okay.
Certainly. And then I have to also make a note here that, of course, it depends on the size of the fibroid in question, because you may find that if it's a huge fibroid, which is maybe like 20 centimeters, surgery may be a little challenging.
Ambitious. Yes. Okay.
I wouldn't say it's impossible, because it depends on your provider and the expertise, but I would certainly say it will be a challenge. Okay. So we normally would say once you've waited for 3 to 6 months, we normally would say the best results, around about 60-70% or so, depending on which study you're looking at, are best gained within the first year. So as with many of these things, the sooner you go back onto, the table to start trying for a baby, or maybe literally not a table, but the other room to start trying for a baby, the better, really, so that we can then see that yes, indeed, it has worked, and you do not need any other, should I say, supportive therapy.
That's fantastic. So that's a run through the thinking behind treatment, and we've gone from medication, hormones, and then we've swung into actual surgery, and then success rates are good. They're sort of above average, depending on the studies. And I know you can't give an exact figure, but it's enough to encourage a woman that if this is the option, if surgery is the option to go for, then it is definitely worth it. And I think as you were talking, it occurred to me that if you're saying to this woman that we're going to get you on the table, have your surgery or have your operation within 3 months without any complications, you've recovered from surgery, really, she should be thinking about everything possible. You're talking about preserving fertility. So making sure she's got a healthy diet, healthy weight, avoiding stress, and all the, the health life measures, really, to make sure that while she's recovering from surgery, all that is in place, and she can start trying with her partner. They can start trying as soon as possible within that year to get the best chance of success. I think that's a positive note to look at for fertility issues. Fantastic. So let's go to the next question. Dr. Tolu, I don't know if you want to add any nuggets to this, but it says, if I'm planning to conceive in the future, what steps can I take to optimize my chances of a successful pregnancy while managing my fibroids?
I think the only extra thing I might want to focus on here might be the use of preconceptual vitamins, just to, get her in that, to give her the best optimum environment for that baby.
Yeah.
Before I let us carry on, I would want to make a little point of reference here, and that's because I've met a few ladies who have come to my practice seeking treatment for their fibroids and saying, "Oh, I want this done, I want that done," when in actual fact their fertility is yet to be tested. And why do I say this? Because somehow they may wrangle the way through the system, but if at the time you're having your fibroid surgery done, you're yet to have a partner, and you're of a certain age where we know that the egg reserve is beginning to go on its decline, I would really beg of you to consider those interventions very carefully. I've once had a 39-year-old lady, and I think off the top of my head, I've had a 42 or 43-year-old lady come to me who, in my personal opinion, did not have a huge impact. Their fibroids didn't have such a huge impact on them compared to another lady down the street. Yes, maybe so, but they were able to get on with things. You know what I mean? It didn't have a huge impact on their quality of life, I think is what I'm trying to say here.
Right.
And neither of them had a partner. Neither of them had a possible partner or a partner in progress. PIP, as I would say. And they were insistent on having surgery. Yes, they got listed, but the unfortunate thing is, because they got listed, got done, they had nothing to test, as it were. I remember what I said about the success of the surgery is best within the first year.
Yeah.
They lost that opportunity.
Oh, wow. Wow.
They
Okay.
love it. Yeah. So I would say to women, yes, you want your fibroids treated. Yes, you want it treated. But please, 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 particularly if you're looking at it from a fertility point of view.
Point of
It's a
view.
different thing if you're looking at it from maybe a bleeding point of view or a pressure point of view. But if
Yeah.
you're looking at it from a fertility point of view, I mean, we all can understand 39, 43,
Yes.
those
Of
ages
course.
already,
Yes.
you're already asking
Yes.
yourself, what are your chances?
Yes.
Certainly getting a partner, to help you, or if in the absence of a partner, if we were looking at a donor insemination. Now, I know this is going to draw a lot of angst amongst people of African extraction, particularly Nigerians, who might feel, what did she just say? But I'm sorry, it is what it is. I have to speak as a scientist here.
Yes, of
Okay,
course. Yeah.
rather than my ethnic coloration. So if you're looking at donor insemination or donor, I don't know what to call it, donor sperm.
Yes.
Please, 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 please. In order to optimize your chances, I know some are lucky enough to wait a few years and they're lucky and they fall pregnant eventually. Yes, but our observation from the point of view of science, even though the numbers are very few and therefore open to question, is not necessarily the case. And if you're undergoing that sort of major surgery, particularly if you're having an open myomectomy, whereby a big cut has to be made, I would say to the girls, you need to optimize everything you can get from the surgery in the first 1 year, because that's when we know the best benefit is. There's residual success, but you can imagine it ebbs down or it ebbs up as the years go by.
Okay, I think that's really brilliant advice, really something to chew on. And can I just ask you, because it does come up, maybe not frequently, and I wonder what your thoughts are as a gynecologist about women in those categories, 39, 40, early 40s, who don't have a partner, or actually maybe somebody who's younger, maybe in her mid 30s or early 30s, and doesn't have a partner, but is thinking, could my fibroids affect my fertility? It makes sense, doesn't it, for such a person to consider egg freezing? What are your thoughts? Would you say yes, or how would you feel about that?
I completely agree. I concur to that. And I think egg freezing is certainly getting cheaper as the years go by and technologies improve. I would say to any woman that is, in her, should I say, ebbing towards her mid-30s, so 32, 33, 34, 35, who's saying to me, what, having a baby is not what I'm looking at this point in time. I need to sort my career out, or I'm yet to find the gentleman, or, or whatever the reason may be.
Many reasons.
Please consider egg freezing. Consider egg freezing. Consider egg freezing. The technologies are getting better. The days whereby we worry about wastage. Yes, the wastage is still there, but it's definitely not as much as it used to be before. So I would certainly say, please, that's something to consider, And then, even with the fibroid uterus, excuse me, we've had many celebrities, some of whom I would want to name, but I don't want to because I don't want them coming after me. Who have, for whatever reason, either because she doesn't want to lose in shape as an actress, because at the end of the day, you might want to think, oh, really? Why doesn't she want to put in weight? But that is what sells for her. That is what brings home a salary for her. So who am I to criticize that? You know what I mean?
Yes.
That shape is why the producers go after her and the movie directors go after her. So there you go. So we've had situations where surrogacy is now becoming the norm, in certain circles. So the fact that they're not bothering you, largely, and then you're worried about the impact it has on fertility. It's a potential impact. You've not even tried and tested it.
Yes.
You see. And you want to go through that sort of major surgery. And you have to also remember there is a very small risk. Things are getting better, but I do remember that if you go through the literature for the risk of a hysterectomy at the time of a myomectomy, the figures are still the figures being quoted are still relatively significant. Well, we all know within the field, because of the advances in interventions, that those figures are no longer as, should I say, correct as they used to be, but there is still that small risk. You can't take it away.
So these are the risk of complications. If you enter with a myomectomy but have to proceed to a hysterectomy, the complications are still quite high.
Yes. So in my mind, you going for surgery all on the back of I worry about this, I worry about that. You've not even tried and tested it. I think it's got to be a very, very careful, progression to surgery. More so with so much available. Egg freezing, surrogacy, just name it. And then I think there's a gentleman who is looking to making commercial surrogates. So basically has a room full of incubators.
Oh, wow.
I'm not quite sure where they are with that. So you don't even need to get a human to be your surrogate. You just sign into this facility. But anyway, like I said, this is still very, very early stages. So people
still experimental. Fantastic, marvelous. There's so much to chew on that, but I'm so glad that in regards to that question, there is a lot that can be done to optimize the chances. So a woman doesn't have to feel that means that she's doomed in some instance not to have a family if she wishes to. Of course, we speak generally, and of course, one has to talk about the access or availability of these interventions. It is not equal across the world. We know that. So there are still ladies who will be in very distressing situations, but don't have access to these things simply because of where they're located or some other circumstances. So it's good to say that we're speaking generally, talking of what is available, what studies and research does show is available in some parts of the world. Okay, so we're going to our very last question as we round up this excellent discussion. I have learned such a lot, really, particularly in terms of discussion with our ladies. I think this has been so useful, and I know that we've touched this before. I'm just going to squeeze to the slide, I think, that refers to this for you. And so, Dr. Tolu, just leave you to give us any tips, any things that you want your ladies just to draw their attention to in respect to lifestyle changes, diet, that can help with fertility for women in this category.
Yeah, so certainly I would say try to minimize your red meat, try to minimize saturated fats in your diet, alcohol, caffeine, please also put that, reduce your intake. Certainly has a positive effect even when pregnant, so not just to fall pregnant, but even in pregnancy. Yes, and you also want to optimize weight, preferably a BMI of less than 30. Then, of course, you want to have reach a diet of fruits and nuts. We know that selenium, which is an important micronutrient for the men, we find in nuts. So the cashews, the pistachios, you want to really get on board with that. You also might want to consider other adjunctive therapy, but however you need good advice with regards to that, because what you do not want to do is to start some therapy that may be abortifacient in nature.
Oh, okay.
So with the herbal remedies, you've got to be very careful that whatever you're taking will not, yes, improve your fertility, but also, unfortunately, increase the risk of early miscarriage. So this is why you need expert advice. You need to do a lot of research and make sure you get expert advice from whoever your herbal, or should I say your herbalist is.
Yeah.
or provider is. Yes, I have to be careful with the word herbalist because it means different things in different cultures.
Traditional medicine practitioner, alternative medicine practitioner, we've got different terms for these practitioners.
And then, of course, you want to minimize your stress. We do know categorically that a heightened anxiety or a heightened stress level in a woman seeking to have babies has a negative impact on her fertility. Yes. And likewise, even in the men, we've had several studies that's been able to actually identify the correlation. So one study I remember very off the top of my head is a study that I think that happened down in southeast London, where once women were placed on a waiting list, they found that I think as much as 40 to 60% of the women on their long waiting list for fertility treatment actually fell pregnant by themselves.
Interesting.
So just knowing that, well, you're on a waiting list and you're going to get there at some point.
Yes. The placebo effect, well, the optimism, I think, and the hope it confers. Yes.
So, yes, those are the sort of things I would say for those who are looking to improve their fertility in individuals that have fibroids.
Marvelous. Oh my goodness. Do you know we have been here for an hour plus, and this discussion could continue. We could carry on and on and on and just keep on talking about this, but we have to come to a stop at some point. Dr. Tolu, thank you so much. Thank you so much for really exploring this subject for us in great detail and shining light on some of the things that we assume. And I'm so glad that you've come at it with this degree of optimism, this degree of their possibilities there, because it's an area where lots of our ladies feel very down, depressed, not just the pressure symptoms or the bleeding symptoms, the fertility issues, as you said at the beginning, the impact this could have potentially on women. So thank you so much for this. We know that you are on Instagram as @vulvadoc. So if you want to go ahead and follow Dr. Tolu on Instagram as @vulvadoc, see what she gets up to on her platform. And we are also at AskAwayHealth. I hope that this has been very informative. And if you're watching this and you have questions around some of these measures that we've talked about, around some of these explanations that have been provided, then please send a message through our email health information service. The link will be in the description box for you. And of course, if you've got any comments or any observations or your experience that you might want to share with regards to fertility, we're always happy to hear from you. This is a very safe space for us to have discussion. So Dr. Tolu, thank you so very much. It's been a great pleasure speaking with you.
I would like to say thank you for inviting me along to your platform, which I find very enriching. I would want to say to the women, please, this is only a guide. It is not the be all and end all. We want you to use this information as a sort of reprieve, but you still need to have that detailed, in-depth conversation with your healthcare provider, because provision vary across the board, even within the same country. So do not say, oh, I've been told this and that, and therefore not want to engage. Please engage with them, because at the end of the day, they want what's best for you, and they want what's best for your babies when they do arrive. So yes. Thank you so much for your time.
Thank you. Amazing. That's excellent advice. On this very useful note, we're going to end the stream here. Thank you so much for watching, guys. Please don't forget to like this video and share it with a friend. We need to get this information out there. There's so many nuggets. I can't count how many nuggets that we've literally dropped in the last hour that will benefit so many women out there. So please share and come back and watch more videos. We publish videos every week throughout this Fibroids Awareness Month. We're publishing videos daily, content for you to learn from, experiences that you can share. And I hope that you will come back and watch one of them, or come back and join us on one of our live streams as well. All right, guys, so we'll be seeing you again soon. Take care. Bye-bye.